we can start the session.
So good evening, everyone. Very warm welcome to the another PG program of Maharashtra Ophthalmic Society. This month of March 2024, we are bringing the most awaited and most asked topic, which is cataract surgery. And cataract case is something either in a traumatic cataract or a post-keratoplastic cataract, you will be 100% getting in your exam. And we are going to discuss the cataract cases in this and the next session as well. Today we will be discussing majorly the traumatic cataract and the posterior polar cataract. And to present that, we have the SRTR Medical College, our postgraduate students, final year, Dr. Javaria Sheikh and Dr. Samiksha. They have been trained under the mentorship of Dr. Shirke sir, and Dr. Shirke sir is professor, head of the department at SRTR Medical College. He is one man army there, and if you want to actually see the high volume work and what one person can do, you can definitely visit SRTR Medical College. He does PG activities, surgical camps, he does high volume surgical camps and everything on his own. Thank you, Dr. Shekhe sir, for mentoring the students and for being here. We have Dr. Saurabh Patwardhan sir and Dr. Matthew Kurian sir as our mentors. Dr. Saurabh Patwardhan sir does not need any introduction. He is the director of Nandali Pai Hospital, Sangli, and he is the AIMS alumni. He had a gold medal during his postgraduate education. More than that, we know him for his FACO training module. He has trained number of fellows for FACO fellowship, and he is the first one to start refractive surgery like Smile in the interiors of the Maharashtra and doing very well with that. Thank you, Saurav sir, for your teaching module and the multiple YouTube videos. We have Dr. Matthew Kurian sir as our mentor, who is our national panelist for today. Sir is the superintendent and the chief of Chaitanya Hospital in Kerala. Sir is an alumni of St. John's Medical College. He was also heading the cataract and the refractive department at Narayan Netralaya, and he is my mentor too. Thank you, Matthew sir, for taking out your time. Somewhere, if I have seen the phacosurgical diagrams actually happening is Matthew sir's surgery. It is exactly the book picture replica when he operates, and we can see through his surgical videos. To handle the whole show, we have Dr. Manish Wankhede sir as zonal member and a very active, dynamic person from Buldana who will be handling the whole show. Before starting and handing over to Manish Wankhede sir, I would like to thank and warm welcome to our president, Dr. Santosh Agarwal sir and Dr. Atul Kadane sir. With their brainchild and with their motivation, we are doing this program throughout the year. And thank you, Santosh sir and Atul sir, for being there and motivating us for each and everything and every program that we do. Santosh sir, your few words before we start the program.
Yeah, thank you, Sumit. Respected seniors, teachers, dear colleagues, and postgraduate friends, very good evening and warm welcome to you all. At the outset, I earnestly thank Dr. Vardhaman, Dr. Sumit, Dr. Shelke, Professor SRTR Medical College, Ambejogai, esteemed panelists, Dr. Saurabh, Dr. Matthews, Dr. Manish, and today's case presenters, Dr. Samiksha and Dr. Sheikh Javeria, for contributing your precious time for today's webinar. Today's webinar, we are going to have presentation by two postgraduates from SRTR Medical College, Ambejogai, in relation to cataract, which is very near and dear topic for all. I appeal all PGs to focus on how to present the case, the examination techniques, do and don'ts, treatment strategy, along with the question and answer related to it. We are fortunate to have distinguished faculties today to throw light on nuances of this important topic. Hence, please do hear them carefully. I hope the key takeaways from the in-depth discussion would definitely help you in your practical exams. Thank you all for your patient listening and giving me this opportunity to speak. My today's quote is, learning is never done without error. A little progress on each day adds big results. Thank you very much, Sumit. Over to you.
Thank you, sir. Without wasting much of a time, I would request Dr. Javaria to present and Dr. Manish Wankhede sir to take over. Dr. Javaria, you can share your slides.
Yes. So my screen is visible?
Yeah, very much. You can start the presentation.
Okay. So good evening everyone. I am Dr. Javeria Sheikh, Junior Resident from SRTR GMC Ambajogai. First of all, I'd like to thank Mos for giving me this opportunity. I would also like to thank my mentor Dr. E.B. Shetke sir, Professor and HOD Department of Ophthalmology, SRTR GMC Ambajogai, for guiding me throughout the presentation. So I would like to move forward with my presentation. A 25-year-old male patient, laborer by occupation, resident of a nearby village, came to ophthalmology OPD with chief complaint of diminution of vision in his right eye since 2 months. History of presenting illness. Patient was apparently alright 2 months back when he had a blunt trauma on his right eye by a stone while working. He then visited a nearby hospital and took required treatment. Then gradually he developed diminution of vision in his right eye over a period of 2 months, which was painless and progressive. Patient didn't have any other complaint at the time of presentation. Negative history. There was no history of any ocular surgery or spectacle use. There was no history of pain or redness, discharge or watering, foreign body sensation, photophobia, headache or nausea, and there is no history of any attack of red painful eye. Past history, there was no history of any drug allergy or any systemic illness. He visited an ophthalmologist 2 months back at the time of injury, but treatment details were not available. Family history was not significant and personal history was normal. Coming to the general examination, patient was conscious, cooperative and well oriented to time, place and person. His vitals were stable and no abnormality were detected. On systemic examination, CVS, RS, CNS and per abdominal examination were within normal limits. On ocular examination, head posture, facial symmetry and eye alignment were normal. Extraocular movement were full and free in all the direction of gazes. And visual acuity in right eye was finger pointing close to face, which was not improving on pinhole, and in left eye it was 6 by 6. Moving forward, I will like to present my right eye examination findings as left eye was within normal limit. Eyebrow, eyelid, eyelashes were normal. Conjunctiva was normal, cornea was clear, anterior chamber was normal in depth and coid. Iris shows presence of posterior synecdoche at 2 and 3 o'clock. Pupil was dilated, irregular, and not reactive to light. Lens shows presence of pearly white reflex. Iris pigment were dispersed on anterior capsule. There was no anterior capsular tear or no zonular dehiscence were noted. Intraocular pressure by non-contact tonometry in right eye was 14 mm of mercury and in left eye it was 16 mm of mercury. Sac syringing was patent in both the eyes. On direct ophthalmoscopy, in right eye, media was hazy due to cataract and rest details were not appreciated, whereas in left eye, the fundus examination was normal. Here is the clinical picture of my case. A B scan was done to rule out any posterior segment pathology or intraocular foreign body, which was within normal limit. So my provisional diagnosis for the case is right eye traumatic cataract and left.
I think there is a net problem, I think.
Javaria, can you hear us? Shelke sir? All three of them. All three of them had an internet issue. Anyway, it was a case of traumatic cataract, as we understood. So before they join, Manish sir, can we directly start the panelist question and then come back to PGs as and how they join?
Yes, sir, definitely.
Yeah.
Sir, as we have esteemed panelists with us, I will like to get solved some few of the most common queries we usually have to face during the operating cataract surgeries. One of such question is, sir, if a post-traumatic cataract has developed the uveitis, do you routinely prefer the intraoperative or preoperative steroids before operating such traumatic cataracts?
If I may answer, so preoperatively, during the clinical examination, a lot depends on the amount of anterior segment inflammation. If there is a traumatic uveitis, then certainly a preoperative course of topical steroids with NSAIDs plus minus an antibiotic would be indicated. Once the preoperative condition of the anterior chamber is little quiet, then we can plan to proceed with the surgery. If the inflammation is related to cortex, which is in the anterior chamber, then I think maybe even a short course of oral is required, and surgery would be earlier in that case rather than later. But if it is just a traumatic iritis, then topical steroids with NSAID should take care of the problem. I would also consider the use of homatropin or atropine eye drops to relieve any ciliary spasm, pain, and discomfort to the patient.
Sir, in routine practice, do we use the intracameral triamcinolone wash in traumatic cataract to prevent the post-operative uveitis like complications?
So I typically don't use triamcinolone for this purpose. If I suspect that there is a vitreous prolapse or something like that, I would use triamcinolone intraoperatively. But if there has been significant trauma and preoperatively the inflammation was high and intraoperatively there was more tissue handling, I would use intracameral dexamethasone rather than triamcinolone. Your thoughts on this, Dr. Saurav?
Yeah, sorry, I didn't get you. I couldn't hear in between. This was regarding post-traumatic uveitis, Manish, or?
Sir, it is regarding the use of steroids intraoperatively and preoperatively in the cases of traumatic cataracts.
Traumatic, okay. So as a routine, I don't use preoperative steroids for traumatic cataracts. And intraoperatively also, I don't use triamcinolone unless there is a vitreous, I need anti-vitrectomy. But post-operatively, I titrate the dose of steroids according to the reaction that I see. And I think one thing I wanted to just, clear for the students is that after trauma, if there is a iridocyclitis or if there is an increased IOP, we have to first decide whether the cause, the treatment is surgical or medical. Because if there is a, for example, say phacolytic uveitis, or, because of ruptured capsule, there is a uveitis, or if it is a phacomorphic, that means or phacotopic, the lens has subluxated anteriorly and caused high IOP, there is no point in, treating it medically for a very long time. And I think Dr. Kurian sir also mentioned that if the treatment is surgical, then we have to opt for the surgical treatment as early as possible. And same is true for uveitis as well. If it is because of, say, bleed, or there is suppose it may not be a cataract, it may be a IOL which is touching the iris and causing recurrent iritis, ectopic IOL or something like that, then treat the cause rather than just keep on treating with the medical management.
Okay, thank you, sir. Sir, I may extend the question more. Sir, how should I continue or?
Yes, sir, you continue the panelist discussion and then we'll come back to Dr. Sheikh.
Sir, what is your comments on the nexus in preoperative traumatic dehiscence of the capsule?
So, in most situations, achieving a good rexus is going to be a challenge. If it is intumescent cataract, there is raised intralenticular pressure, then you have to treat it increase use a heavy molecular weight viscoelastic. My preference is viscode for this. No financial disclosures over here. Tamponade and flatten out the anterior, the domed anterior capsule, flatten it out. It's a good exercise to do an anterior segment OCT in these patients preoperatively. You can see the water clefts and fluid and the position of the fluid. If it's very close under the capsule, then the fluid will come out once you make a puncture. But if it is a little deep and there is a layer sheet of cortex between the capsule and the fluid, then the fluid will push the sheet of cortex, and immediately you make a puncture, you'll have a rhexis which runs off. So first is to assess where the fluid is, to use a heavy molecular viscoelastic, tamponade it, and 3, in all these cases, I don't use a cystitome needle. I typically use a microrhexis forceps through the side port in a pressurized anterior chamber and try to make a very small rhexis, maybe 2-3 millimeters. Control that, complete a rhexis. Then this loose fluffy cortex can be aspirated either by irrigation aspiration or by the phaco probe. Once the intralenticular pressure is reduced, then you can confidently do a double rhexis and control it. The second situation obviously is where there is a rhexis anterior capsule rupture. That you have to try and make it as close to a rhexis as possible. If it is not possible to include the tear into the rhexis, then my preference is to not leave 1 or 2 weak areas in the anterior capsule. I would do a proper 360-degree anterior canoplar capsulotomy and then proceed with the surgery.
Saurav, sir?
Yeah, I think the term post-traumatic cataract doesn't indicate a one type of cataract. I think it can be combination of so many things. Like Kurian sir just said that the anterior capsule may be ruptured. It may be ruptured equator to equator, or it may be a localized rupture which is seen. The trauma can be blunt or sharp. It may be associated with various degrees of zonular instability. So we have to treat it accordingly. Also, some like it may not be an acute trauma, it may be old trauma where there might be a fibrosis or fibrous capsule kind of partially absorbed cataract. So I think it's a variety of cases under traumatic cataract that we see, and we have to treat and plan accordingly. Once you see the patient, I think you have to plan beforehand what you are going to expect in that particular surgery and keep all your armamentarium ready to take care of these situations.
Yeah, I think you need to have a plan A at the beginning of surgery, but be prepared for plan B, C, D, because so often you will have unexpected surprises as you're proceeding.
Sir, to add, Manish, just a second. Just to, sir, like you said, this cataract is very fluffy and very soft, and you can aspirate, sir. Once I had tried in such a cataract, hypermat kind of a thing, traumatic. We pierce with the needle and try to debulk the nucleus, like you said, the fluid. But then that cortex was so fluffy that most of the cortex came out, and it became like a small shrunken bag. And then the rhexis was way more difficult than otherwise. So where to stop exactly when you're trying to debulk, or you just debulk for a till the capsule flattens, it doesn't wrinkle up, and then you come out. Is there any way to understand it, where to stop the debulking?
I think if there is a dome-shaped capsule, you want it reasonably flat. And at that stage, you can stop. I find that using a cystitome needle combination is much more challenging. And in my hands, microrhexis forceps through the side port is probably what works best for me. I've not had issues with Argentina flag sign, etc. Since I switched to this combination.
Manish, sir, go ahead.
Sir, okay. Sir, most of such post-traumatic cases generally have glaucoma and cataract side by side. Sir, how to manage the preoperative IOP, and what is the role of mannitol in such cases?
So for me, preoperative, like Saurav said, there are many entities possible in blunt trauma. So I would be looking very carefully for what would be the cause. Get a gonioscopy done if possible, and look at angle recession, look at cyclodialysis, look at posterior synechic creating an iris bombay, understand the cause, and then take it up. If manageable by topical anti-glaucoma medications, I would do that. But most likely the underlying cause for the glaucoma is going to be some issue related to the trauma itself, and it's going to be often primarily surgical management. So removing the lens itself in many situations will solve the major impact of the glaucoma. And then you have to look long-term also. The surgery may solve the immediate problem, but long-term also these people can develop delayed glaucoma due to angle recession, the cyclodialysis closing up and creating fibrotic tissue there. And so I typically put these individuals on 3 to 6 monthly follow-up after the surgery is performed and everything is quiet also.
Saurav sir, what is the role of mannitol in such situation, particularly preoperative situation?
Yeah, so in case of traumatic cataracts, if there is raised IOP or if there is a, the intumescent kind of cataract, preoperative mannitol, if the IOP is high, definitely helps. But it's useful mainly if the IOP is raised. Otherwise, it's not of much significance. Another thing is in these patients, in traumatic cataracts, I generally prefer to give subtenon anesthesia rather than trying to do it on topical anesthesia, because many of these patients are generally young and they tend to move their eyes often. And with these, kind of cataracts where you want the eye to be soft when you're operating rather than eye to be tense, and patient should not be moving the eyes because that may affect, the surgical outcome. So I generally prefer anesthesia. I think regarding the management of cataract and glaucoma for traumatic, I think as Kurian sir said, I generally don't try to combine it in one step, because glaucoma surgical procedures generally have poor outcome if there is an inflammation right at the beginning when we are operating. So always better to medically control the IOP, do the cataract surgery if cataract is significant, wait for a few months to let the inflammation subside, and then glaucoma surgery will, do a better job in such situation.
So what is your preferred post-operative regime? Any special things in post-operative prescriptions?
So I generally give oral steroids for these patients, particularly younger patients. I see after around 5 days to check how the response is, if the inflammation is well down. If the inflammation is well controlled, then I start tapering it off. And topical steroids, I generally, in my routine cataract surgeries, I just abruptly stop steroids after 7 to 10 days. But for these patients, I generally taper steroids off over a period of 4 weeks.
Okay.
My routine for post-operative cataract, uneventful adult cataract, is 4-3-2-1 weekly taper of the steroid and an NSAID which goes on for 6 weeks. But for cases like this, or where there is an intraoperative excessive tissue handling, complication, etc., I have a more intense regime, which may or may not include oral steroids. But typically, I start them at maybe hourly steroids in the first week, then 2 hourly, then 4-3-2-1. So it will be a 6 weeks taper. And if there is a significant inflammatory component, it won't be a weekly taper, but it would be just maybe even as low as a 2-weekly or 3-weekly taper. So the likelihood of rebound uveitis immediately on stopping is much higher. So that would be my typical regime. Antibiotic, I like to keep separate. I just use it for 2 weeks. NSAIDs will also continue. Often these individuals will have significant amount of cystoid edema and posterior segment changes as well. So I like to keep the NSAID on for about 6 to 8 weeks.
Saurabh,
yeah.
sir, since both of you are here, sorry to interrupt, Manish sir.
Yes.
Like from the last webinar, or we had a discussion on this, and there are a few surgeons nowadays who stop the steroids along with the antibiotics at 2 weeks, and they only keep the patients on NSAID. Your comments on that? Have you ever tried it, or is it not worth trying?
Yeah, so last almost 5 years I am doing that. So I use antibiotic and steroid just for 10 days and 4 times a day, and then they are abruptly stopped. So I don't taper it off, and I start NSAIDs on 6th day, and then it's continued for 6 weeks. So what I have found is that with this regime, the chances of rebound inflammation is quite low. When I was using steroids in a tapering form for 3-4 weeks, the chances of rebound inflammation were little higher. That is because the eye gets kind of addicted to steroids, and whenever you stop steroids after a long time, they again patients again have some rebound inflammation and need steroids. So that has been my experience.
So sorry
So
to
I tend to
yeah.
use this. Yeah,
No, no, sir.
I tend to use this intense regime only in very rare specific situations. Not it's not the routine practice.
Okay. Saurabh sir, why NSAIDs on the 6th day? Why not from the first day itself?
Yeah, we can start from the first day itself, but just I think patient prefer to keep less number of drops to begin with, and anyway because steroids are there, and NSAIDs do not take time to start working. Like it's not so that even if you start on 5th, 6th, or 7th day, they will start working immediately. So there is no loading dose required for NSAIDs as such. So I just need it to cover when steroids are stopped.
And choice of NSAID is
Nepafenec, yeah.
We'll go back to Manish sir. We'll go back to Sheikh sir for the questions to Dr. Sheikh, which we had left in between because of net issue. Sheikh sir, can you ask questions to Dr. Javaria for her presentation?
I think he has to
Sheikh
unmute.
sir, you need to unmute yourself.
Can you hear me?
Yes, sir, very well.
Zavaria, how the cataract is formed in trauma in case of blunt trauma? How it is developed?
Yes, sir, sure, sir. So there are various mechanisms responsible for formation of cataract post blunt trauma. Important ones are COWP, counter COWP, and equatorial expansion mechanism. So COWP is a mechanism of direct impact. It is responsible for osseous ring formation, which is sometimes seen on the anterior capsule. Second one is counter COWP mechanism. It refers to the distance injury caused by shock wave traveling along the line of concussion. And the third one is equatorial expansion. When the anterior surface of eye is struck bluntly, there is a rapid anteroposterior compression which is accompanied by equatorial expansion. This stretching in turn leads to the disruption of the anterior capsule or zonules or both. Now this combination of curve, counter curve and equatorial expansion in turn leads to imbibition of fluid in the lens fiber which causes the opacification of lens.
Okay. And if the anterior capsule if it is ruptured, then what is the mechanism? How the cataract is developed?
So if the anterior capsule is ruptured, then the aqueous humor directly enters the lens fibers and which in turn leads to opacification of lens fibers.
Okay. Tell me 7 rings that are seen in case of blunt trauma.
Okay, sir, sure, sir. So, 7 rings of trauma are 7 distinct circumferentially oriented ocular structures which are anterior to equator, and they are classically damaged in case of blunt trauma, specifically in closed lobe injuries. So, this structure involved are as follows. First one is the sphincter pupillae. So, disruption of the sphincter pupillae may lead to distortion of the pupil and diminished response to the light, and also it may cause traumatic mydriasis. Second structure is the root of iris. So damage to the root of iris causes iridodialysis. Third structure is anterior ciliary body. Disruption to anterior ciliary body may lead to angle recession, which may cause angle recession glaucoma. Fourth structure is the separation of ciliary muscle fiber from the sclera, which causes cyclodialysis cleft, which in turn lead to hypotony maculopathy. Fifth one is the trabecular meshwork. Damage to the trabecular meshwork in long term may cause the glaucoma. Sixth structure is zonu. Disruption to the zonu may cause zonular dialysis or dehiscence, which according to the extent can be seen as phacodonosis, subluxation or dislocation of the lens. And the seventh structure is the disinsertion of the retina at ora serrata, and it is most common in infratemporal quadrant.
Okay, these are the 7 rings. First is sphincter pupillae that may be teared. Second is iris base, that is ID is happened. Third one is angle recession, in that anterior ciliary body is damaged. Fourth one is separation of ciliary body muscle from scleral spur. Fifth one is trabecular meshwork tear. Sixth one is zonular dehiscence, and seventh one is RD from ora serrata, right? Retinal detachment. But how will you manage a case of zonular dialysis if it is less than 3 o'clock?
So the mild zonular dehiscence, which is less than 3 to 4 clock hours, can be managed by using a capsular tension ring. Using a capsular tension ring can reboost the capsular support, and it may be helpful in cataract extraction as well as IOL implantation.
Okay. If it is more than 3 o'clock, or 150 degree or 180 degree.
So then also we can use a CTR ring, but like modified CTR rings are available, and also there is a capsular tension segments are there, which are newer devices for the management of zonular dehiscence.
Okay. What investigations you will do pre-operatively in a case of traumatic cataract? Most important.
Yes, sir. So first one is the visual acuity, sir. Visual acuity is important for the pre-operative baseline vision. Also, if the lenticular opacification and visual acuity are not properly if the visual acuity and the lenticular opacity is not disproportionate, then there may be a posterior segment pathology present. And so second one is the slit lamp examination. A thorough slit lamp examination is important for a detailed information regarding anterior segment. We had to look for the various structures, like in conjunctiva, we had to look for subconjunctival hemorrhage or chemosis. In cornea, we'll look for the abrasion, laceration, or tear. And in case of penetrating trauma, we will also find out the wound of entry. In anterior chamber assessment, we have to look for the depth and also the content of anterior chamber. If there is presence of any inflammatory exudate or hyphema or cortex in case of anterior capsular rupture. Also, we have to see for the iris of your iridodialysis or iridodonosis. And in pupillary area, we have to look for the lens opacification, anterior capsular tear, and we have to do a detailed fundoscopic examination to look for the choroidal rupture or retinal damage, retinal detachment. Third one is the sir intraocular pressure. Intraocular pressure may be raised or decreased depending upon the type of injury. Another investigation is ultrasonography like A scan and B scan. B scan can give idea regarding the posterior segment pathology and presence or absence of intraocular foreign body. Also, sir, other radiological examination like X-ray or CT scan can be done to rule out any orbital fractures or intraocular foreign body. And anterior segment OCT can also be done to look for the extended integrity of posterior capsule and zonules.
Okay.
Very
Over to you, Sumit sir.
Sir, can we proceed to a next case presentation by Dr. Samiksha?
One small observation I have.
Yes.
An important aspect of potential zonular dialysis patient examination is not just the slit lamp examination, but to make the patient lie down and then examine, because you may have a person sitting up. If there is an inferior dialysis, the lens is still vertical. Okay. Once the person lies down, you may see that it is tilting maybe 10 degree, 15 degree, 45 degree. And depending upon the extent of tilt, you would then need to have a vitreoretinal support or other changes. Okay.
Yes, thanks.
I think, and one more important thing for any cataract examination, traumatic or otherwise, is pupillary reflexes. That is the first thing which should be done even before checking the vision or putting any drops, I think, because that gives a lot of information about how the posterior segment is working, even if there is a mature cataract. That should not be missed.
Yes.
One more thing I would like to add, sir, is pupillary reaction is also very important in that case, the very because we can know the optic nerve status, right? If there is optic nerve avulsion or some damage to the optic nerve, there will be pupillary reaction will be affected, right? There will be RAPD or pupil will be semi-dilated, not reacting to light.
Yes.
That's why pupillary reaction is also very important. Sir, over to you, Sumit.
Dr. Samiksha, can you please share your screen?
Yes, sir.
Sir, my screen is visible, huh?
Not
Yes,
yet.
yes, right. Sumit.
Yes.
Now we can.
Yes. Good evening, everyone. Myself, Dr. Samiksha Parate, Junior Resident 3, SRTR GMC Ambazogai. Firstly, I would like to thank Mos for giving me this opportunity. Also, I would like to thank my guide and mentor, Dr. E.B. Sherke, sir, for guiding me with this presentation. So, I will start with my presentation. Chief complaint: a 45-year-old female patient resident of Ambazogai came to ophthalmology OPD with chief complaint of diminishing of vision in both eyes since 18 months. History of present illness: patient was apparently all right 18 months back, then she started experiencing diminishing of vision in both the eyes, which was gradual in onset, painful, progressive to reach the present stage. Negative history: there is no history of photophobia, watering, sticky discharge, pain, redness, foreign body sensation, headache, any ocular surgery, ocular trauma, and spectacle use. In past history, there is no history of diabetes mellitus, hypertension, no history of bronchial asthma, tuberculosis. There is no history of any drug allergy. In family history, there is no similar complaint in the family members. Patient has, in personal history, patient has normal appetite, sleep, bowel bladder habit, and there is no history of substance use. General examination: patient is conscious, cooperative, well oriented to time, place, and person. General condition is fair. Patient was afebrile. Vitals were stable. There is no evidence of pellar, cyanosis, icterus, clubbing, edema, and lymphadenopathy. Systemic examination: CVS, RS, CNS, and per abdominal examination was within normal limits. In ocular examination, visual acuity: firstly, I would like to go with right eye. Unaided vision was 660, which was not improving with pinhole. Near vision was N10 on Jaguar's chart, and color vision was normal. In the left eye, unaided vision was 636, which was not improving with pinhole. Near vision was N10, and color vision was normal. Head posture, forehead, chin, facial symmetry, eye alignment was normal. Extraocular movements were full and free in all the direction of gazes. In both the eyes, eyebrow, eyelid, eyelashes, and cilias were normal. Conjunctiva was normal in both the eyes. Similarly, cornea in both the eyes has normal shape, size. Surface was regular, transparent. Corneal sensations were present in all the quadrants of cornea. Anterior chamber has normal depth and content according to the Van Herrick's grade 4. Iris has normal color pattern. Pupil was normal in size, that is 3 mm round, regular, and reacting to light. Lens has grayish white reflex with round onion ring like discoid opacity, densely adherent to the central posterior capsule, suggestive of posterior polar cataract. Intraocular pressure was 16 mm of Hg with applanation tonometer. Sac syringing was patent. On fundus examination with direct ophthalmoscopy in both the eyes, media was hazy due to cataract. Optic disc has normal shape, size, color. CD ratio was 0.3. Margins are distinct. Blood vessels were normal. Foveal reflex was present and periphery was healthy and normal. This is the clinical appearance of posterior polar cataract. Note the discoid shape opacity in the center of posterior capsule. So for provisional diagnosis for this case is in both the eyes, patient has posterior polar cataract, which was more in the right eye than left eye. Thank you.
May I request Sheke sir to please ask the questions?
Samiksha, what are the causes of posterior polar cataract?
Sir, posterior polar cataract, it has a gene mutation, mostly autosomal dominant inheritance. Mostly it is due to the persistence of hyaloid artery, then which fails to regress. Secondly, it is due to the invasion of lens by the mesoblastic tissue, which causes abnormality in the lens development, specifically in the lens fiber, and which fails to develop normally and forms opacity in the posterior capsule.
Okay. And what are the clinical features? Slit lamp.
Clinical features seen on, yes, sir. Clinical features seen on slit lamp is the opacity will be dense, circular, central plaque-like with concentric ring around the central plaque, giving the appearance of bullseye or onion peel appearance on slit lamp.
What pre-operative investigations you will do to find out the PC status?
Yes, sir. For PC status, sir, firstly we will go with the slit lamp examination, followed by retroillumination, and if needed, we'll go for anterior segment OCT, sir.
Okay. Tell me the incidence of PCR and basic precautions to be taken intraoperatively.
Yes, sir. The incidence of PCR is more in phacoemulsification, and incidence of posterior polar cataract is 3 to 5 per 1,000 population. And sir, if the positive family history is present, there are chances the 40 to 50% population will have posterior polar cataract in the next generation, sir. And sir, basic precautions to be taken intraoperatively are we should follow the gentle manual while operating, then avoid anterior chamber collapse. We should avoid hydrodissection, nuclear rotation, then posterior capsule polishing, and IOL manipulation. Sir. Elevation of flap during capsular exit should be gentle. Then avoid vigorous hydrodissection and other hydro procedures. Sir, avoid aggressive nucleotomy techniques and cracking of the nucleus should be avoided, sir.
Okay. And what are the early signs of PCR intraoperative?
Yes, sir. During intraoperatively, it can be identified by deepening of anterior chamber, sudden appearance of red reflex, then distortion of pupil, sir, appearance of vitreous strand around the instrument tip, then difficulty in rotating the nucleus, which was earlier rotating, then difficulty in aspiration of cortex. So there can be a frank descent of nuclear material into the vitreous, and there may be lens doesn't appear in the center, which was usually appear in the center.
Okay. Over to you, Manish sir.
With this, I will like to ask esteemed panelists, sir, what is your way of handling such cases? Dr. Kurian, sir?
So, my typical management for posterior polar is to make central rexus less than 5 uh, 5.5 millimeters, not a very large rexus, because I do not have any idea in which case there will be a rent, and I want to always have the option to do a optic capture of a 6 millimeter optic lens in these individuals. So it will be a 5.5 millimeter rexus in all cases. Most of these posterior polars will be soft, and so remove the anterior epinucleus. If it is possible, I will do a limited hydrodelineation, no hydrodissection. I will do a hydrodelineation and just try to pick up the core central portion of the endonucleus and emulsify it. Once that is done, I would attack the distal epinucleus using my phaco probe itself. Not with position 3, in position 1 or 2, just vacuum, gently try to lift the epinucleus ball out of the capsular bag without rotation. So it would be an in situ nucleus management without rotation. And once the epinucleus is also out, my comfort levels are higher. Never allow the chamber to collapse. Go in for a bimanual IA, attacking the posterior plate, especially if it is adherent, very firmly adherent to the posterior capsule. Attack that area last, and then gentle maneuvers, like she said correctly, and place in a single piece IOL in the back. But for all posterior polars, I will have a 3-piece IOL, foldable or rigid, depending on the package the patient has chosen, which I will use in the event the PC opens up for a IOL placement in the sulcus, haptics in the sulcus with optic capture through the rexus margin.
Saurabh, sir, any particulars about the phaco parameters and special techniques about handling these cases?
Yeah, so I think the basic idea which has evolved over a period of time, particularly with phaco, is that we should, keep the eye in the physiological position as far as possible all throughout the surgery. So there should not be sudden deepening as well as sudden shallowing of the antechamber, because both these things are not good. So it's not so that only shallowing of the AC will cause rupture. It's also the excessive deepening of the AC also causes posterior capsular dehiscence. And I have described a new technique for tackling these cases, where we can remove the nucleus without rotation. If it's allowed, I will just show a brief clip of that. The
Yes,
technique
please,
is
sir.
already now published in IJO. I will just share my screen. I'm sorry, okay, let me just check. Okay, so this is the technique. Is it visible now?
Yes, sir.
Yes, sir.
I will just go to the technique part. Okay, so this is posterior polar cataract, but relatively dense, because if it is very soft, we can, as Dr. Kurian sir said, we can just go layer by layer and aspirate it. But if it is slightly dense, a grade 1 or 2, then what I do is that I make the first range, and unlike the regular trench divide where we rotate the nucleus and then trench on the other side, what I do is that without rotation of the nucleus, I just start moving my phacoprobe sideways. So it's kind of sideways trenching, okay, without rotation of the nucleus. And you can do this up to grade 3 cataract. Above that, it's slightly difficult because grade 4 cataract is very difficult to divide. So in those cases, I think better to go for SICS. But here, as you can see, I made a sideways trench and I divided the nucleus in situ. And then I will go with the side trench on the other side. Just I will forward it. And now I have 4 divisions, just like 4 quadrant technique. And once I have 4 divisions, I don't have to rotate the nucleus. I just have to pull the pieces to the center and emulsify. So that's, I have named it as sideways sculpting technique for posterior polar cataracts. And now it's published in IGO as a surgical technique. Another important thing which I wanted to tell about the optic capture. Okay, so I will just go to the optic capture video. I think as this was another case, post-traumatic cataract, where there was a pre-existing posterior capsular rupture. So I have removed the nucleus by phaco, but you can see the rupture is there with fibrous edges, indicating that it was a pre-existing rupture. And here the CCC should not be more than 5.2 mm, as sir was saying, and ideal is 4.8. So if it is more than 4.8, we may have, sometimes we may plan optic capture, but it doesn't actually happen on table. And what if you have planned optic capture, then the IL power is different, because if if you have decided to do optic capture, you can use the same IL power as it was planned, as in the bag. But if you have not planned anti-optic capture, then we have to reduce the IL power by 5%. Now, this makes a difference in final surgical outcome for the patient, because we want to, give patient exact hematropia as far as possible. So before you implant IOL, just you have to plan whether I can do optic capture or not. If your rhexis is not central, it is eccentric, and if it is slightly larger in size, and if you achieve only a optic capture on one side, what happens post-operatively is that there is a IOL tilt, and there is an unnecessary astigmatism induced by the IOL tilt. So you do either optic capture on both sides or don't do optic capture. Don't do one-sided optic capture. Also, for optic capture, the ideal IOL is 3-piece. If you try to do it with PMMA IOL, or if you try to do it with hydrophilic IOL, which have a large optic haptic junction, it doesn't happen. On table, you might feel that you have done the optic capture, but post-operatively, it just slips and comes anteriorly. So don't try with IOLs which are not designed for optic capture. And I will just show the technique of optic capture now. Okay, the IOL goes in. I will just skip. Okay. Now let me play the video. So now already the IOL is in the sulcus. Now I'm going behind the IOL to remove all the OVD, or if there is any vitreous behind, I will just remove that. Removing the OVD behind the IOL helps in maintaining the IOP post-operatively. Otherwise, we may have IOP spikes or inflammation afterwards. So it's better to just remove that OVD behind the IOL. Now, when you do the optic capture, don't push suddenly directly in the center. It's better to push from one side, okay, and then on the other side. So the CCCs should become exactly spindle shaped. So that is something you have to observe. Now watch here, the CCC is still not spindle shaped. So right now the optic capture is still not complete. Okay, now when I push it down, okay, when I will further push it down, it will be exactly spindle. So unless, now you can see, once I pushed it down, now it has become spindle shape. So if it is not exactly like a spindle, it's partial optic capture, and post-op, as I said, there might be optic tilt because it's not completely captured. And remember, once you have done optic capture, if there is a subsequent shallowing of the anterior chamber, it's going to come out. Okay, so once you have done optic capture, make sure that AC keeps formed all the time. And if there is a shallowing of the anterior chamber like it happened here, you can see the optic just came out from the optic capture. So again, I have to nudge the IOL optic back and achieve the optic capture again. So until at the end of the surgery, you have to be watchful that the optic capture is really there or not. Because believe me, even if you have a complication of PC rupture, if you achieve good optic capture, the patients are extremely happy post-operatively. And if you give a good refractive outcome as well, I think it works very well. Okay.
Thank you, Saurabh sir. It is always an excellent teachings and the videos by you, particularly this new technique for handling the posterior polar cataract. I will take this opportunity to trouble esteemed panelists more, and I will present a few case scenarios. Sumit sir, should I present this?
Yes, sir. Sir, meanwhile, on this regard, I wanted to add the anterior vitrectomy, which becomes very important in such cases. If Matthew sir can throw light on the settings of anterior vitrectomy, that what should be ideal in such scenario, Matthew sir.
Yeah, I have a short video on that as well,
Yes.
and I can share my screen. Is my screen visible?
Yes, sir. Yes, sir, we can.
Okay. So for anterior vitrectomy settings, just remember that today almost all the machines have two options. One is the IA cut option, which is irrigation. Second foot position is aspiration and vitrectomy. And this is used only to remove the cortex from the anterior chamber. Should not be used when there is vitreous in the anterior chamber. So this setting, your cut rate is very low. IOP is whatever standard that is available, and vacuum can be depending upon the density of the residual cortical strands. And very gently, this is to be used after the vitreous has been cleared from the anterior chamber and is used for clearing any residual vitreous strands. And on the foot pedal itself, we can control and go back to a cut IA mode as required if there is vitreous prolapsing to the anterior chamber. The typical standard method of doing is cut IA, where in foot position 2, we have cutting, and so here you can see foot position 2, there is more than 1,000 odd cuts. The ideal thing would be to have as high cut rate as possible for the machine. Vacuum is slightly lower, so my typical settings for vacuum in the vitrectomy in phaco would be 300, 500 for the vitrectomy settings would be like about 100, 200, that range. And IOP, since today we are not operating at 100, 110 bottle height, IOP is at a more physiological 40s, 20 in the individual situation. And this bimanual approach, separating irrigation and aspiration, is very critical and can be assisted by triamcinolone assisted. Most important to remember that this should not be the way of doing bimanual. It should not be through the main port. This is theoretically bimanual, but it is eliminating all the advantages of a closed chamber bimanual method. And triamcinolone acetonide at the end of the procedure is very, very useful and important to confirm that there is complete vitreous removal from the anterior chamber.
Thank you, sir.
So much, sir. Manish sir, you can go ahead
Back
with
to
your...
you, Subbu.
Manish sir, you can go ahead with your case.
Yes, sir. So today I will like to share two simple case scenarios which I have faced recently in my routine OT.
Sir, can you make it full screen, please, Manish sir?
Yes. Is it okay now, sir?
Perfect, sir.
Okay.
This was a routine cataract, grade NS3. I was doing a routine for cataract surgery for this case. Everything went very well until the removal of the lens and cataract. We can see even the visco was very well placed. I started my cortical aspiration, irrigation aspiration in this procedure, and nothing was expected in such case. The case was routine, and the problem actually starts when I change my hands for irrigation aspiration, and as I started noticing the PC is starting to bulge forward, and I was having such expressions at that point, and I was trying to form the AC again. It was very difficult to remove the remaining cortex. I tried to push the visco from main port and side port, and we can see the PC was actually coming up. I tried to remove the speculum, but AC was not getting formed. I pushed the high density viscoelastic, changed the speculum, and waited for particularly 5 to 10 minutes, but it was not possible for me to proceed further for IOL implantation. And again, sir, what is your take? Why this happened actually? Why suddenly the pieces start bulging out? How to proceed? How should I proceed further?
Yeah, should I answer?
Yes, sir, please.
Okay. So I think which particular phaco machine you are using?
Sir, I'm using Centurion.
And with the IOP control?
No, sir, it was with gravity.
Gravity. Okay. So this is typically a fluid deviation. Of course, one of the differential diagnosis here is a impending suprachoroidal hemorrhage. That is the reason why we always think whether we should go ahead with pars plana tap or not. So a couple of things where here I need to ask is whether patient was experiencing any pain or not at this point.
No, sir, patient was not experiencing any pain at that point.
Right.
But he was little bit uncomfortable. I was waiting and waiting for nearly 10 minutes. This procedure totally took nearly 10 minutes for me.
Yeah. So if patient is not having any pain in such situation, I would like to wait for not 10 minutes, but maybe 2-3 minutes and inject viscoelastic from the side port and try to pressurize the chamber and wait for some time. Many times this fluid which is collected in the Burgess space may get dissipated in just some time. Okay, because it's a porous thing. It has gone through the zonules and accumulated in the Burgess space. So if you wait for some time, as you rightly did, sometimes it just dissipates and you can go ahead with the routine surgery. Otherwise, the second way to do is just make take a maybe 23 gauge MVR, go through the pars plana, just go in and come out. Okay, that's it. You don't have to even do vitrectomy, and the trap fluid from the Burgess space will disseminate, and you can go ahead with the surgery. But if that is not happening, just close the case, take up the patient next day. By that time, the AC will be deep enough, and you can just put the IOL and come out.
Sir, I will ask one more question for this.
And IV mannitol, like if you are waiting for some time, like you want to take up the case immediately, say after 2-3 hours, you can also try IV mannitol. But I don't know whether it will work immediately or not.
Sir, any particular
A rapid infusion of IV mannitol certainly will help. Okay, it should be a rapid infusion, and you may be able to complete the case on the same day. But in all these situations, I think the differential diagnosis of a potential expulsive is always there. So I hesitate. I would do. I would not attempt to forcefully form the anterior chamber. I would use mannitol, see if the patient settles. And the most critical thing is what Saurabh said just now, is that pain. Absence of pain, you are most likely safe. Presence of pain, that is almost certainly like expulsive happening there.
Yeah, just
And what I have noticed over a period of time, like you are I think asking for tips to avoid such scenarios. So I used to have this more often when I was using the force infusion type of machine like Constellation or gravity force infusion where I was using very high bottle height. In those situations, in those cases, this happens little bit more frequently than if we use lower IOP like Centurion with lower IOP if you are using. and if you are using dispersive heavy viscoelastic agent. So what I have noticed is that if I use say Hylucoat at the beginning of the surgery, it not only protects the endothelium, but it also presses the peripheral iris down, because peripheral iris is the one where we are not using any infusion, so fluid doesn't go in that. So this heavy dispersive agent kind of presses the peripheral iris down, and the chances of this fluid deviation is quite low. And this I am talking about surgeons who are doing surgery in 10-15 minutes. But any surgeon who has prolonged surgical time, obviously the chances of this happening always increases, because then you have more chance of fluid going through the zonules and accumulating.
Yeah, Manish, I just want to add one or two things about it.
Yes, sir.
When this happens, pain is very important, as already suggested by our panelists. So if pain is there, that means some expulsive is happening. You have to close the case. But if it is not there, I think we can go ahead with the pars plana, and little antervitrectomy also we can attempt to reduce the or to vent the pressure, and you can save the or salvage the eye, because there are unforeseen complications that can happen if you attempt to go inside the antechamber. So many things can happen and we can lose the case. So better to do pars plana vitrectomy, antravitrectomy, and it will relieve the pressure, and you can go ahead with the routine our phaco surgery. That is my experience. I usually do whenever there is a high IOP during phaco.
Sir, what if the patient is under peribulbar anesthesia? How we notice that he is painful?
That is, still he patient gets pain, but
Okay,
when
sir.
there is expulsive, patient gets pain, some pain.
Okay.
And when
Sir,
there is a patient discomfort, many times patients are apprehensive. You ask patient to take deep breathing. Many times it relieves your intraocular pressure. That is also my experience.
yes.
Another
Sir,
thing that I would like to point is we need to look at the biometry preoperatively in these individuals carefully. So if the individual has got a small anterior segment, white to white is less than 10.75, the AC depth is less than 2.5, then this is relative to the rest of the eye. It is a what do you call a relatively small anterior relative anterior microphthalmos. These individuals have a intact normal posterior segment, and the likelihood of aqueous misdirection in this is more the cause for raised intraoperative hard eye. But if the eye has got a small posterior segment less than 22 axial length, then with or without a crowded anterior segment, then the posterior segment is abnormal, preoperative choroidal thickness may be high, and these are the individuals where your diagnosis is more likely to be expulsive rather than fluid misdirection.
my third question got answered, sir. Thank you. Sir, this is how I proceeded in this case. I do a pars plana of 26 needle gauge entry and vented a little bit of vitreous, and it solved my problem then.
Yeah.
I placed the IOL. Sir, another such example of fluid misdirection, not exactly fluid misdirection, but this was my case, which I observed routinely recently. Sir, I injected in a blue dye for staining the capsule, and it went through the zonules in the vitreous cavity, and I have to operate the whole case in this blue glow. So maybe, sir, zonular laxity was can be one of such causes in such situation for the fluid to get misdirected in the vitreous.
Yes, and one of the things whenever you are injecting dye, of course, I think many surgeons put it under the air. So you take it in a 1 cc tuberculin syringe. First, we take dye and then withdraw a little bit of air. And as you inject, what happens when the air fills the anterior chamber? When you put the dye, it usually drops over the anterior capsule rather than it doesn't go as a jet into the equator. So this is true all throughout. Whenever you are operating, never direct any jet of fluid towards the zonular area, that is between the iris and the anterior capsule. There is always a chance of fluid misdirection happening because of such jet of fluid.
Sir, let me go to another case scenario. This was the case. I was operating, it was a routine cataract surgery, and I have operated on the pterygium first before starting the case, and everything went very well. Nothing is suspicious in the whole case, that anything about the integrity of the posterior capsule, and I operated it routinely as I operate routine cases. But suddenly, when I was about to complete my total nucleus removal, I noticed a small posterior capsular dehiscence just in front of the tip. And look at this. And I can see a few cortex, a few pieces of the cortex going in the vitreous cavity, and they are coming again to the anterior chamber back. But in the whole this case scenario and this situation, the tear didn't extended. So I was curious about whether this was a pre-existing posterior capsular dehiscence or rupture, or I made it during the cataract surgery.
You should not have withdrawal suddenly. The way you withdraw, that is also must have increased the tear, Manish.
But it didn't increase, sir.
It didn't. Yeah. So you know why this happens? This is because again the fluid misdirection. So the Berger space gets filled with the fluid. Okay, it pushes the posterior capsule up, and during your particularly last piece, because now the nucleus is not pushing the PC down, that is when you get a tear. And usually in such situation there is no vitreous. That is because the antihyaloid is intact. You are just punched into the posterior capsule and no vitreous.
Okay. So this was maybe the punch out PCR, maybe the cause that PCR didn't get enlarged.
No, it will not enlarge unless there is a push from the vitreous.
Yeah.
Okay.
Or there is lot of shallowing of the anterior chamber. It's a redundant PC. So if you have a punch, it will not enlarge.
Okay. Okay. So what will be the oil of choice in such situation, in the bag or a 3-piece with optic capture?
So it depends on how big is the punch. So generally, of course, safest choice will be 3-piece without any thoughts. But sometimes you want to put a toric, I'll say, or you want to put a multifocal or something like that. So if it is an inferior large peripheral, rupture or open PC, then I would avoid putting anything in the bag, because with gravity, and usually if it is after the capsule starts fibrosing, because on table it may appear central, but once the capsule starts fibrosing, it usually will decenter. But if it is very small, say tiny, say 2 millimeter, and it is in the periphery and not particularly in the inferior area, then you can safely put the IL in the bag without any issue.
I choose the 3-piece IL with optic capture.
Yeah,
in this
3-piece
case.
is safest option in such case.
Okay. Sir, Sumit sir, any more question?
Nothing I said. Atul sir, Santosh sir, Matthew sir, any comment, any questions further?
And Manish, the difference between pre-existing PC rupture and one which happens on table is that if there is pre-existing PC, defect, it always have a area of fibrosis around it. So if there is area of fibrosis, that means it was pre-existing. Otherwise, it's a fresh PC rupture.
Okay. Thank you, sir.
Also, if a rupture is very small, you can make it PCC also. Posterior capsular X, you can make it, convert it to PCC.
Yeah, but only if it is central. If it is peripheral, then there is no use of converting.
I think that brings to the end of the discussion and end of the today's session. It was very nice discussion overall on all the cases and of course the surgery and its complication. I would like to hand over to Dr. Atul sir, our secretary for Atul sir.
Yeah, yes, I'm here. Hello.
Yes, sir, we can.
Yeah, thank you very much. It was indeed a very nice PG program, and our Manish from Buldana had made it very good presentation of his cases. So much to learn from them, and a very nice presentation by Samiksha and Sheikh Zaveria. I must thanks the panelists, Dr. Saurabh sir, Dr. Matthew sir, for giving us their valuable time and enlighten us about the various small intricacies in the management of the complicated cases. Must have been a lot of take-home messages for the members as well as the budding new surgeons. Thank you, Sherke sir, for mentoring the two students. And of course, the man behind the show, Dr. Sumit. It takes a lot of pains for all of us to make this program vibrant, and it is very appealing, and every Thursday we are looking forward for the new program from him. Thank you, President, and thank you all. Thank you, Entod, for supporting us in the cause. Thank you.
So just one appeal to all members of our MOS that we are celebrating this month as a glaucoma awareness and screening month. So there is one form which is floated by Dr. Atul Kadane, our secretary. So please fill that form and take part in this activity, various activities run by MOS. So I appeal all to please take part in these activities.
Yeah. Thank you, sir, for
Thank you so much.
this. Yeah. It is there in almost all groups. Everywhere you can see the Google form link is there in in MOS official groups as well as the.
It is starting from 12th of March, which is a World Glaucoma Day, till 30th of March.
Okay.
Sir, Sumit sir, these presentations and discussions will definitely help the PGs, and as PGs are presenting the case, and later on your expert opinion and panel discussion, definitely the PGs will confidently and boldly will appear the exams.
Yes, sir.
I take this opportunity to ask our PGs whether they like these programs or not. Anybody can give their feedback.
Yes, sir. It was very much interesting and.
Sir, it was very much interesting and.
Yeah, is it useful for your practical
Definitely,
exams?
sir. Yes, sir.
Saurabh, you want to comment any suggestions or any modification we should make to make it more fruitful?
No, I think this is a very good because for postgraduate students, I think more they practice such presentation and in front of so many people, I think more confident they get, and also then they will avoid missing on any points. So that kind of practice really helps.
Dr. Kurian, sir?
Yeah, I think this kind of deliberate practice, you cannot present confidently if you have not done it before. And often it is not the lack of knowledge, it is the presence of a crowd and an audience which makes the person tongue-tied. So the multiple times you present it in front of an audience, you are grilled, cross-questioned, and you are lose your inhibitions and anxieties before your exams, you will take the exam very comfortably. I think this is a good program, and I'll think I will institute something like this for Kerala Ophthalmic Society and Cochin Ophthalmology Club. So yeah. Thank you, Sumit, for introducing me to these kind of concepts.
Thank you, sir. Thank you, everyone, for giving your valuable time. Sumit, please.
It's been a pleasure. Thank you to members of MOS Dr. Santosh, Dr. Salkir, Dr. Atul, and Saurabh. It's a pleasure as always. Sumit, thank you so much.
Thank you, sir.
Thank you, sir. Thank you.